And then, I always tell our residents, beware of the small empyema. Small empyemas are also very dangerous. These virtually all get taken to the OR for drainage. So you on the head CT, the teaching point here, you all, is when you're looking at a head CT and somebody that's got completely opacified frontal sinuses, you want to look very carefully for subdural or epidural empyemas or edema in the brain parenchyma as a sign of, say, cerebritis. Intracranial spread of infection is something we need to do, and we need to make this call on this very thin empyema that's pretty hard to see on CT. It's nearly isoattenuating to brain, and these can have kind of some variable appearance. They can be more hypoattenuating, and sometimes they can be more isoattenuating. Hematomas are brighter than this, so we didn't think this was a hematoma, and we didn't have during this we didn't have trauma. All right, so excellent. You all doing a great job here.
Can I ask a question?
Absolutely.
Okay, I have two questions. I was wondering why a contrast study wasn't done.
So yeah, your question is very good. So you're always going to start with a non-contrast head CT, right? And that's what they started with, because they really didn't know this person had sinusitis. They just came into our emergency room complaining of headaches. So they could have had anything. They could have had intracranial hemorrhage, I mean, a brain tumor, they could have had anything. So they started with this. The next study could have been a head CT with contrast. You are right. That could have been. We have access to brain MRI in our hospital. It's very easy to get. And MRI just will give you more information. It is very confirmatory, because we knew with the MRI that we had restricted diffusion in the subdural spaces. There was no differential going on here once we got the MRI. We knew 100% that we were dealing with a subdural empyema. But
okay.
so the MRI is really better. Also shows you other things. It would have showed us if there was any subtle brain edema that we couldn't see on CT, because MRI is more sensitive for that. It would have shown. So MRI is, in this setting, if you can get it, is a better study. But if you can't get an MRI, the next study to get would have been a head CT with contrast, and that would have shown us the enhancing subdural empyema. And in the setting of the opacified sinuses, we would have still said this is probably a subdural empyema. I will tell you, in our hospital, when we have younger children that get this, say a 3-year-old, 3-year-olds can't do an MRI without anesthesia because they can't be still, as you know. So for a younger child, we would have done a CT with contrast. But with adults, if they can tolerate the MRI, because we have one in our hospital, we'll go to that next.
Okay.
But a CT with contrast would have been very acceptable.
Okay. But can we call this condition a Pott's puffy tumor?
So Pott's puffy tumor typically has the frontal scalp edema with a scalp abscess next to the frontal sinuses. This person didn't have that. So when you use the word Pott's puffy tumor, you're referring to a subgaleal frontal scalp abscess. This person just didn't have that. Sometimes they do, just this patient didn't have that. Does that make sense?
Yes, thank you.
Yes, of course. But you're right. In a case of frontal sinusitis, you want to look for Pott's puffy tumor. All right, let's move to a next case. This is kind of an important case because I think it's very easy to be missed. So this was a 68-year-old female who initially presented with some left-sided orbital chemosis. And, just to remind everybody what chemosis is, it's when you get sort of redness of the sclera of the globe of the eye. and you get some edema sometimes of the periorbital soft tissues. And so she developed this. Her primary care physician thought she had, conjunctivitis, infection of the eye. So she got treated with antibiotics. The chemosis persisted. It was just not going away. She got multiple rounds of antibiotics. And then she started to feel like her eye was bulging out. She developed some proptosis. And then 4 weeks later, got a left sixth nerve palsy. So that kind of stimulated the imaging. So she comes in for imaging. And in patients that have kind of redness of the eye or chemosis, the first study that most people are going to get is going to be this one on the left. This is an orbit CT with contrast. Remember, we don't need an orbit CT with and without contrast. We only need a with contrast study. And we're going to give contrast, and then we're going to image about 90 seconds after we give the administration of the contrast. And we're looking for post-septal or retrobulbar orbital infection and abscess. So here's her left orbit, her right orbit, and there is a little bit of proptosis, pretty subtle. And there are all these sort of stranding areas, but there's stranding areas on both sides, and they look a little vascular. There was no abscess, but look at this structure here and this structure here. These, if you're looking coronal, they're just under are just inferior to the superior rectus muscle. These are the superior ophthalmic veins. And if you look on them, the left one is bigger than the right. Now, I'm going to say we see that all the time in normal people. So just because your superior ophthalmic vein on one side is bigger than the other doesn't mean it's pathologic necessarily. But we've got a patient that's got chemosis for a long time, got some proptosis, and notice they really don't have a lot of periorbital or superficial edema. This is just not looking like an infection. Most infections, people have a lot of swelling of the preseptal or periorbital soft tissues, and this has been going on for weeks. So we recommended a CTA to look further at the vessels. Now, this is their CTA on this side, all right? And remember, when we're doing CT angiography, we're going to give the same contrast, right, that we give for an orbit CT, but the difference is instead of imaging at 90 seconds, we image at about 15 seconds. So we're imaging at a time where the contrast is really mostly in the arteries and not in the veins. And if you look at the orbits in coronal on the CTA, here's your superior rectus muscles. Remember, right under that's going to be the superior ophthalmic vein. And this is CTA. And so well-timed CTA. There really wasn't much contrast at all in the veins on this study. If you look over here, here's an internal control. This is one of the external carotid artery branches, the superficial temporal artery. And this is how the arteries are enhancing. Look at our superior ophthalmic vein. It's enhancing just as avidly or densely as the arteries. So we have venous arterial opacification of our superior ophthalmic vein on the side where we've got the proptosis. We had no real infectious symptoms. We didn't really, we didn't have an abscess. So with this imaging, what are you all worried about? And this is a tricky case.
A fistula.
Yes,
Arterial
absolutely.
vein.
Yes, you are worried about arterial venous fistula. You are absolutely correct. And so one of the ways to look further at that, which we did do, 3D time of flight MR angiography actually turns out to be a really good study or screening study that's non-invasive for fistula. And we did do this in this patient. So this is MRA of the head. So we don't need contrast, right, for this. This bright signal saying the basilar artery here is signal. It's not enhancement. And this, you should see really good arterial signal on MRA. And if you look here, look at our cavernous carotid arteries. They have great signal, but look on the left. We have this kind of sort of fainter, but, ill-defined signal all around our left cavernous carotid artery. And this is our supraophthalmic vein. Look, it has arterial intensity signal in the vein. And notice our other veins, like look at the superior sagittal sinus. We don't see any signal in that. So this is also confirmatory for what we think is a carotid artery to cavernous sinus fistula. So what would be the next study to do? What do you think we did next? So our next thing, I agree with you all. I think there's a fistula.
The
next
conventional
thing,
angiogram.
angiogram.
yes, you all are all over it. You're correct. And that's what we did. So the gold standard now for kind of confirming and also evaluating the complexity of the AV fistula is to do a catheter directed, conventional, digitally subtracted angiogram. And here, what this is a frontal view. What vessel did we inject? What do you think based on what you're seeing? Common carotid or internal carotid?
Common carotid.
Yeah, common carotid, because see, we've got branches of the external opacified. But here is our internal carotid artery, our cervical carotid. Here's our petrous carotid. Here's our cavernous carotid, supraclinal carotid. Here's our A1 and A2 segments of our anterior cerebral artery, M1, M2 segments. And we've got this faint enhancement adjacent to our cavernous carotid artery on the right, going across the midline. And notice we're very early in our arterial run here. Notice we haven't even filled out our distal vessels yet. And this turns out to be a vein. We should not be seeing any venous contrast yet. This is too early in the run. And when we go a little further, our vessels are filling out our arteries, but we still shouldn't see veins. And here we have an opacified cavernous sinus. Remember, the cavernous sinuses are connected to each other by the circular sinus. So we've got contrast going into our right cavernous sinus, going across the midline into our left. This is the supraophthalmic vein. And you are correct. We have a fistula here, a carotid artery, cavernous carotid artery to cavernous sinus fistula, what we call a CC fistula, or dural AVM. And you can see here it is on the lateral view. So let's talk about these. I bring these up because it is really important as radiologists. We've got to be the people that see these on orbit CTs and suggest the CTA and suggest the workup. There are different names for these. People will call these cavernous sinus dural AVMs. They're also called indirect CC fistulas. A direct CC fistula would happen in trauma often, where you get a tear in the cavernous carotid artery with a fistula, or a direct fistula could happen with a ruptured cavernous carotid aneurysm. But these are actually also called dural AVMs. And why do they happen? Well, we think patients get some partial thrombosis of their cavernous sinus, for instance, and then thrombosis leads to inflammation, neovascularization, angiogenesis, and the adjacent arterioles next to the dural venous sinus are stimulated to form pathologic shunts to the venous channels. Here's this. I did not draw this. I got this from the literature, but I like this drawing because it kind of makes you think of how do these dural AVFs, AV fistulas or AVMs occur. And if you think about it, if you, for instance, this is the transverse sigmoid sinus, which is another common location for these to occur. If you got partial thrombosis of this, they're little arterioles that are, supplying blood supply to the dura. And the inflammation associated with thrombus will stimulate the little arterioles around it to form shunts to the venous sinus to kind of recanalize it, and you can get little arterioles from both the external carotid and internal carotid filling, connecting to the dural venous sinuses, and this is how these AVFs can form. You can have a single arteriovenous fistula, but in my experience, it's almost always multifocal complex feeders, and they can involve dural venous sinuses anywhere. The transverse sinus and cavernous sinuses are the most common locations. It's, again, I want to really emphasize the importance of us as radiologists to see these. We had a patient come into our hospital just a few weeks ago with a giant frontal lobe hemorrhage, and it was from one of these fistulas that on the some outside hospitals had missed it on orbital CTs. And it's not always the easiest thing to see, so when you have someone that is kind of, that's being presented as, chemosis and all, you want to take a really good look and ask yourself, any chance they have a CC fistula? Because what happens when the arteries are directly connected to the veins, it raises the venous pressure and it puts patient at risk for intracranial hemorrhages, like a patient that we saw not that long ago here. So again, you want to be looking for that on your orbit CTs. All right, let's go to the next case, and y'all just stop me if you have questions. Next case, this is a 5-year-old who presented with several weeks of progressive headaches. They kind of had headaches off and on, but the headaches got, markedly worse. So they were brought in and they got this head CT. All right. Well, this is not very mysterious. Needless to say, the ventricles are huge, right? Especially the lateral ventricles. Look at the third ventricle is really rounded. The temporal horns are markedly enlarged. And again, the earliest signs of hydrocephalus, of course, are rounding of the third ventricle and enlargement of the temporal horns. Now, when you see someone with hydrocephalus, the next thing you need to do is say, do I think this person has kind of compensated hydrocephalus, or are they uncompensated and in real danger of herniation? And there's 2 signs of uncompensated hydrocephalus are very dangerous. And one of them is this hypoattenuation in the periventricular white matter. This is what we call transependymal flow of CSF, or periventricular edema. We think that CSF is trying to get out of the ventricles, gets pushed into the adjacent brain, and we get edema in the adjacent brain. This is a very dangerous sign. The other dangerous sign is sulcal effacement. So you want to go up to the vertex and say, do I see any sul sign? If you look here, there's no sul sign. All we see is edema. So this is a patient at very high risk to herniate from their hydrocephalus. Now, while the lateral and third ventricles are really big, look at the fourth ventricle. It's normal, all right? And we do sagittal reconstructions of our non-contrast CTs, and you can see, look at our normal fourth ventricle. Our third ventricle is huge. Our lateral ventricles are big. And then this is the tectal plate, the superior and inferior colliculus. It looks a little bulbous with sort of this funnel-shaped appearance of the proximal cerebral aqueduct. So what are you worried about here? What are you all
Would it be
worried
a
about?
tectal plate glioma?
Yes, I am too. Tectal plate glioma obstructing the cerebral aqueduct. So if you have access, what would be the next study that you would recommend?
MRI with contrast.
Yes, exactly. And that's what we did. You want to get an MRI with and without contrast, because we want to see, when somebody has hydrocephalus, you want to make sure you understand why they have it. And the MRI can help you. In this case, here is our tectum. Notice it's large and bulbous. We've lost sort of the ability to distinguish the superior and inferior colliculus. And notice it's obstructing our cerebral aqueduct. We've got these large lateral and third ventricles. Notice the thinning of our corpus callosum. Here's our flare, and you can see the transependymal CSF flow or edema. And look carefully at this. Notice our normal fourth ventricle on our T2. But we've got, you can see big temporal horns and transependymal edema. But if you go and look carefully at the level of our tectal plate, notice this hyperintense T2 signal. And you've got to look for that because sometimes you can get aqueductal stenosis just from a web forming in the aqueduct. It doesn't have to be from a tectal glioma. But if you look here, our tectum is enlarged as we saw, and we have abnormal T2 signal in the tectum. Here's our post-contrast T1. There was no enhancement of this area. Okay, so we had no enhancement. And this is a study that we will often do in the setting of aqueductal stenosis. This is an MRI CSF cine flow study where we can look at flow. And you can see, flow will look sort of black or white, if you will. Here's some flow, obviously, in the straight venous sinus and the superior sagittal sinus. And you have to think, our aqueduct is right here, and we don't see any flow in our aqueduct. Notice we have dark signal here and bright signal here at the foramen magnum. We got flow at the foramen magnum, but we have no flow at all in the region of our cerebral aqueduct, and normally you would see some on this. So you all are correct. All of this together, this is a tectal plate glioma with obstructed hydrocephalus at the level of the cerebral aqueduct. And how are these treated? Well, typically they can be treated either with an endoscopic third ventriculostomy or a ventriculoperitoneal shunt. Both are good options. Here, we're going to always start with endoscopic third ventriculostomy because it avoids having a patient have to have a shunt put in place, and shunts carry the risk of breaking or getting infected. So when we don't have to put a shunt in, we try not to, but a VP shunt would be absolutely a perfectly acceptable treatment for this. So what do tectal gliomas look like? They are, first off, they look just like this. They're typically iso-intense on T1, hyperintense on T2, and they usually don't enhance. This is exactly what they look like. They are usually low grade and often very slow growing. So you usually don't actually have to do anything to treat the glioma. It's often very stable. You just need to treat the hydrocephalus typically. Imaging predictors of patients who might need treatment of the actual glioma are people that have gliomas that are more than 2.5 centimeters, or if they enhance, and those are typically treated with radiation. This is a nice graphic from StatDX of, aqueductal stenosis. This person doesn't have a tectal glioma, but, you can see the findings. We have the enlarged lateral and third ventricle. Notice the stretched corpus callosum, the funnel-shaped proximal aqueduct. When we do endoscopic third ventriculostomies, we put an endoscope in. We typically go through the right frontal lobe and into the lateral ventricle. We'll find the choroid plexus, then that it's going along the floor of the lateral ventricle through foramen Monroe, and you'll take your endoscope following that choroid plexus and into the third ventricle. Once the endoscope's in the third ventricle, the surgeons will then look for the mammillary bodies at the floor of the third ventricle, and they always make their opening right here in the floor of the third ventricle, just anterior to the mammillary bodies. And what that does is it bypasses the aqueduct, so the CSF can get out of the lateral and third ventricles and into the prepontine cistern, and it works very well. You make a big enough opening, and endoscopic third ventriculostomy works very well. And so, again, they're going to go through into the lateral ventricle through foramen and Monroe in the third ventricle, and they're going to make their opening right here in the floor of the third ventricle. And that's what they did. So this was the pre-op scan. Post-operatively, after endoscopic third ventriculostomy, the ventricles don't get super small like they often do with a shunt. They'll kind of slowly get smaller. And notice the temporal horns, they are a little bit smaller. This was just performed just a few days after the endoscopic third ventriculostomy. And you notice, again, one of the things, notice on this T2, we don't see our sulci very well preoperatively because of the uncompensated hydrocephalus. And now look, we're seeing our Sylvian fissures, our sulci. So now we're getting, everything's getting better post-operatively from the endoscopic third ventriculostomy. You know, again, here's a nice look. Ventricles, again, aren't going to get super small, but they are going to decrease in size. Notice preoperatively, they were bigger than postoperatively. And our edema is getting better. And now we can see sulci postoperatively that we didn't have preoperatively. Here's another great look. We can see our sulci now at the vertex postoperatively that we couldn't see preoperatively. And then here, of course, our glioma is unchanged in the tectal plate. We will do MRI CSF cine flow studies after endoscopic third ventriculostomies. And notice here, so here's your pons. Notice the flow, this white signal and then black signal here, right through the endoscopic third ventriculostomy. So this is a sign that the third ventriculostomy is patent and open. So it's kind of a cool case, and also kind of, talks, makes you think about, the different treatment for patients that have aqueductal stenosis. They're the one group that would be a candidate for an endoscopic third ventriculostomy, which would save them from having to have a VP shunt in place for the rest of their lives. So going to the next case, and you all stop me if you have questions. I'm just trying to run through some interesting cases. This was a 7-year-old who presented with about, they were fine until about 4 days prior and started getting headaches, and, they stayed home from school, and then developed just a little bit of right-sided kind of clumsiness and weakness. They weren't paralyzed, but they were a little bit weak. So they went to an outside hospital that wasn't ours and got a head CT. And here you can see this area of hypoattenuation. This is the third ventricle, so it's centered in the thalamus. Notice it does have a little bit of mass effect. Ignore these. These are outside of the patient, part of their hair clips. But you can see, so this was thought to be possibly a tumor. And the patient was transferred to our hospital to evaluate a left thalamic tumor. All right, so what study do you think we got next?
MRI with contrast.
Yes,
Yeah,
MRI with and without
I would have,
contrast.
I would have gone for a contrast before an MRI.
Yeah, so it's interesting. I would say this, and here, if you have access to an MRI, there is no reason to do a CT with contrast. If you're going to get the MRI anyway. If you don't have access to MRI, then you would do the CT with contrast. But if you're going to MRI anyway, the CT with contrast is not going to do anything to help you, if that makes sense. But if you don't have access to MRI, not every place does have MRI right there. Lots of places don't. Then a CT with contrast would be absolutely the next step. But we had an MRI, so we didn't spend any time with CT with contrast. We went right to MRI instead. And here you can see our MRI. You can, on the T2, CSF is bright. We see this hyper intense signal centered in the thalamus. And notice we've got some mass effect there. This is our flare, and not surprising, it's very hyper intense overall on the flare. Notice it has mass effect. And this is our diffusion in ADC. So if you look here, like especially over here, we do have some little areas of restricted diffusion. They're bright on diffusion, a little dark on the ADC, but it's not all restricting diffusion. So we're still thinking this could be, you know, a tumor, maybe a cellular tumor, because sometimes diffusion restriction goes with cellular tumor. So, you know, we're thinking that. And here's our T1 pre and post contrast. And there is some areas of a little peripheral enhancement here, you know, again, pre and post contrast. We do have a little bit of peripheral enhancement there. So what is everyone thinking right now? What's your kind of leading diagnosis at this moment? What are you thinking?
So it could be a tumor or maybe a demyelinating disease.
Yeah,
Um,
that was how we were, you know, we were kind of still thinking, I was still thinking probably tumor. That was where I was going. But one of the things I tell our residents every day, when you are reading brain MRI post contrast, it is very important to always look at the arteries and the veins and make sure they're well opacified. The arteries looked good, but look here. Look at, this is the straight sinus. Do you see this filling defect here? And we went, and if you look at the veins, this is the vein of Galen, we have this filling defect. And on this sequence, this is a T1 that's a volumetric acquisition. So in this sequence, we should have normal opacification of our veins, our dural venous sinuses and our deep cerebral veins. And we saw this filling defect going from vein of Galen into the straight sinus, which then made us go back to the internal cerebral vein. And here we had this very subtle linear filling defect in our internal cerebral vein. And then on our susceptibility weighted imaging, which we do, and this is imaging that you use, right, to see hemorrhage or mineralization, we do have some really dark signal in our lesion, like there's a little bit of, you know, maybe petechial blood products. But notice the linear configuration of this dark signal in SWI. And we have dark signal there, susceptibility artifact, we call that dark signal, where our straight sinus was. So we were starting to worry that this could be thrombus in our straight sinus and in a draining vein to the thalamus. So now what do you think we are thinking this whole thing might be? What do you think? With this maybe
Neural venous sinus thrombosis.
Yes, now we're worried that this edema is a venous, you know, dural venous sinus and deep vein thrombosis with edema and early developing infarct instead of tumor. So again, I put this slide up there, you all. Whenever you see a lesion in the brain, you always want to at least go down your, what I call big categories. You know, could this be neoplasm? Could be vascular, infection, inflammatory, which includes demyelinating, autoimmune, paraneoplastic. Could it be toxic? Could it be metabolic? Could it be congenital? And we were sort of in this world. We were thinking neoplasm, but now that we see this dural venous sinus thrombus, now we're wondering if it's vascular. And so we kind of favored that this was a venous infarct and edema of the left thalamus associated with partial thrombosis of the internal cerebral vein, vein of Galen, and straight sinus. And we still left glioma on our differential because people with gliomas are hypercoagulable, but we recommended short-term imaging follow-up. And sure enough, the patient was anticoagulated, and we brought him back 2 weeks later for another MRI. And this was our initial MRI. Now look at it 2 weeks later. It's drastically, the edema has improved. The dural venous sinuses were no longer, there was no more thrombus there. And then 3 months later, we're getting even, you know, it's the edema and the blood products are decreasing. So this is the teaching point on this is one, just be careful. This was billed to us as a glioma. In fact, the patient was scheduled for a biopsy later that day. And it really highlights the importance of looking at your arteries and your dural venous sinuses, because we called off that biopsy and told our surgeons, you know what? This could be a venous infarct and edema from dural venous sinus thrombosis. Let's, you know, bring them back after treatment of that. And sure enough, we saved this child a biopsy in their left thalamus. All right, let's keep going. This next case, and you all stop me if you have questions, but I'm trying to put out some teaching points of things to think about here. So this next case was a 16-year-old who, you know, it was a normal 16-year-old and came in because they had developed some visual complaints that they couldn't describe very well. They felt like their vision was changing and maybe wasn't as good over the last few days. So a pretty quick history, not a long history. Of note, they had a pretty significant viral illness a couple weeks prior. They had, you know, been home from school for a week with fevers and chills and cough and all this. And they were better from that and then developed these symptoms. They got a head CT, which just showed some non-specific hypoattenuating areas in the brain. So they ended up getting an MRI. And here's their MRI. So it's a T2 hyperintense signal in the ventricles. And here you can see we have some rounded lesions in the brain. Where are they? Well, they're in the white matter. And whenever I see lesions in the brain, I always ask myself, is there mass effect and is there a lot of edema around them? Because that's going to help me with my differential. So what do you think about these lesions? Do you think there's a lot of mass effect and edema around these lesions? Especially these two.
No,
I don't see a
I
lot
don't
of
think there's
mass
even.
effect.
Yeah, I agree with you all. You know, this is a pretty big lesion and there's no edema around this thing. And it's sort of sitting there in what we call the juxtacortical white matter, in that white matter right next to the gray matter. We don't have a lot of periventricular lesions. Most of them are juxtacortical. And this is our post-contrast T1. Now, I will say there was nothing bright pre-contrast. So this is all enhancement of our lesions. How would you describe the enhancement of these two lesions? How would you describe that enhancement?
Brim enhancement.
Ring enhancement, I
Open
agree.
ring.
But would you say it's a complete rim or an incomplete ring of enhancement?
Incomplete. C-shaped.
Yes. And what does that make you think?
Demyelinating disease such
Excellent.
as AN.
Yes, it makes you think these could be demyelinating. Incomplete rim of enhancement on lesions, especially lesions that don't have edema, makes you think, you know, could this be demyelinating disease? Now, the emergency room says to you, radiologist, are you sure these aren't infections? This is kind of weird. Why would a 16-year-old get demyelinating disease, they say? So we go to our diffusion ADC and let's look at this lesion. Notice we don't really have any restricted diffusion, especially centrally. And we talked at the very first case, we said, you know, pus tends to have restricted diffusion. So we did not think these were abscesses. Everybody understand that. You understand why I don't think these are bacterial abscesses, because we don't have that central restricted diffusion. Everybody agree?
Yes.
Right?
Yes.
Yes. And so this is our T1 with contrast as well. What are these right here? What do you think these are?
Optic nerves.
Yes. Are they normal? Is that
No.
what they should look like?
No, they look enlarged and enhanced.
Yes, absolutely. Are the optic nerves supposed to enhance normally?
No.
Correct. So this is key. The optic nerves should never enhance. Any enhancement of the optic nerves is abnormal. The optic nerves should look like the brain. You know, they're an extension of the central nervous system, and we have enhancing optic nerves in addition to our lesions with incomplete rim of enhancement. I will say sometimes demyelinating lesions can have complete rim of enhancement. So don't let that throw you off. Sometimes they can, like this one has more of a complete rim. All right. So what's your favorite diagnosis here?
Aiden.
We're going to go down our
Oh, right.
list. What's that? I think everybody's sort of you all been saying this. This turns out to be a case of acute disseminated encephalomyelitis. Now, on imaging, we just said, we thought this was demyelinating, acute demyelinating because of the enhancement. But because the patient had a viral illness just a couple weeks before, we suggested ADEM. Multiple sclerosis was also in our differential. Atypical infections was on the differential, but much lower. Again, typical bacterial abscesses will have central restricted diffusion, but atypical infections won't restrict diffusion. So you have to kind of keep those in mind. But this did turn out to be a case of acute disseminated encephalomyelitis. What does ADEM look like on imaging? You're going to get multifocal hyperintense T2 flare signal lesions in the white matter. And in ADEM, you'll often have basal ganglia lesions. We didn't in this case, but know that ADEM often does have basal ganglia lesions. The white matter lesions of ADEM tend to be more juxtacortical as opposed to periventricular versus MS, multiple sclerosis. The lesions will be more periventricular, kind of at that callosal septal interface. Look for that incomplete rim of enhancement for active acute demyelinating lesions. That's, that imaging characteristic really points you to demyelinating disease. And again, ADEM patients tend to have had an infection. It can happen after people have had, an infection or vaccination, usually 2 to 3 weeks prior. It's typically monophasic. The cranial nerves aren't always involved, but they can be, like they were in this case, and again, here's a juxtacortical lesions are very typical of ADEM. And you want to look for that incomplete rim of enhancement for demyelinating diseases. All right, this is going to be my last case. I hope y'all will have me back because I got more great cases for you all, and you all are fantastic. This is another tricky case, and hits a point. This is a 45-year-old who presented with trigeminal neuralgia, got a brain MRI with and without contrast, not at our hospital, an outside hospital that was read as normal, and they were treated medically. Remember, when you get a case of trigeminal neuralgia, as a radiologist, you need to follow that trigeminal nerve all the way from the brainstem and into the face. Remember the anatomy of that, the nuclear and the posterior pons. We have our cisternal segment of the trigeminal nerve that then goes into into Meckel's cave where the trigeminal ganglion is. And that then we've divided into the V1, V2, and V3 segments that lead the skull base. And again, when I want to find that skull base anatomy on this CT, I'll look for the anteroclinoids. Medial will be the optic canal. Laterally to the anteroclinoid will be the superior orbital fissure. That's the easiest way to find it. Look here. And then the other thing you want to find is the pterygopalatine fossa. If you find the maxillary sinus just posterior, that's the pterygopalatine fossa where V2 is. And then, of course, what is this skull base foramen along the floor of the middle cranial fossa?
Foramen of valley.
Foramen.
That's ovale, where V3 goes, and posterior to that is what?
Spinosum.
Spinosum, where the middle meningeal goes. So this was the initial MRI, and they paid a lot of attention. Here's our pons. This is going to be where our fifth nerve into our trigeminal ganglia. They're sitting in Meckel's cave, which is the CSF filled space, just medial here. And notice, they looked here and we didn't see any enhancement there. And sure enough, they didn't look here, and we'll get back to that. So this was read as normal. The patient developed worsening pain, so they ended up going to a neurosurgeon and got a microvascular decompression where the surgeons did a craniotomy, went in and found a vessel near the trigeminal root entry zone, put a little Teflon felt pledget next to it. Unfortunately, the patient didn't get better, and they got a repeat MRI here with us. Now, what area? These are the maxillary sinuses. What space is this?
Pterygopalatine fossa.
Yes, and it should always be fat filled. Notice on this side it's full of fat and vessels, but look on the side of our trigeminal neuralgia. We've got hypointense tissue there. And if you go into the face, you see some hypointense tissue here. It's our pterygopalatine fossa. And this is our T1 post-contrast fat saturation. Notice our pterygopalatine fossa fat is dark here, which highlights our enhancement in the pterygopalatine fossa, going into foramen rotundum. And then if you go out here, we've got enhancement of a lesion in the face. So what do you think the cause of this trigeminal neuralgia was? This was perineural spread of a squamous cell carcinoma. So unfortunately, the surgeons and neurologists really depend on us not to stop our search right here in trigeminal neuralgia. We as radiologists can't stop here. We've got to, let me go to this, we need to go all the way into the face. And always remember to look at the pterygopalatine fossa, the superior orbital fissure, and also the foramen ovale, because they're very dependent on us finding this. I've seen several cases of this where it's been missed on imaging, and of course the wrong thing gets done for the patient. So I'm going to stop there with this set of cases.
I have a question.
Yeah.
Okay, so why did you think of a malignant cause of the trigeminal neuralgia instead of an infective?
Okay, the reason I think about this is infection would be pretty unusual in this time frame, because we're talking this has gone on for months. And that's why I was thinking tumor. Does that make sense? You're right. If the time course was quicker infection, but because this had gone on for almost a year at this point. Does that make sense?
Okay, yes, it does.
Yes. And again, the neurologists and neurosurgeons are never going to look at the pterygopalatine fossa. They're never going to think of squamous cell carcinoma of the head and neck because they don't treat that disease. So they are super dependent on us. So when you see trigeminal neuralgia, you need to be very diligent to go out into the face because your clinical colleagues are not going to do this. Everybody with me on that? Yes. Again, I've got more cases to show to you all if on another day, but I want to respect your time, and I hope you'll have me back. You all are fabulous, and I appreciate the interaction. I hope I pointed out a couple of key things to pay attention to when you're looking at imaging. Just sort of some more subtle things that as radiologists we can really drive care in the right direction if we're being really careful and diligent to kind of guide treatment when our clinical colleagues are thinking a patient might have something else. So again, I appreciate you all having me, and I hope you have a great day. Dr. Turpening, is there anything you need me to do or you want them to do?
No, thank you so much. That was so good. I don't remember all those, forgot everything about the brain. And for our folks, if you want Dr. Geer to come back and do another session, email me or type in your chat so I know what you want. Because next month we will have MSK, the second Sunday at the same time. It's going to be MSK cases. And if you want more neuro from Dr. Geer, let me know. You all have my email address. Just reply to that email. Thank you, Dr. Geer.
Yeah, thank you all for having me. I had a lot of fun, and I
Thank you
do
so
love
much,
I
Dr.
love
Geer.
doing this with you all, and again, thank you for participating. So I hope y'all have a great rest of your day or evening, depending on your time zone.
Thank you.
Yes,
Thank
bye
you.
everybody.
I'm going to close the webinar.
Bye, Nat.
Bye.